We should probably maybe
Yeah,
take some questions.
Yeah.
Yes? Do we have a timekeeper here? Yes?
Yes.
Is that good? Are we good?
Yeah.
Okay.
Is this, am I recognized or somebody
You
else? San Francisco's mayor and a certain section of the city policymakers make a big deal out of maybe 85 or something inebriates on the street and how much it costs to pick them up and take them to the hospital and take their belongings in a special truck and process them and to do it over and over again. Now, I read that in the Oxygen Revolution, I don't know if you've read that book, but there's hyperbaric oxygen can help a lot of things like strokes and even autism. Now, do you know anything about some alternative to this just sobering litany that costs so much to the city to know have some other ideas about how to handle it? Maybe it's not going to fit the big pharmacy idea, but certainly hyperbaric oxygen wouldn't fit it exactly. It's not like a drug. And do you have, what is your take on this?
I have to say that's one of the many things that I know absolutely nothing about.
Yeah.
I like everything you said, but I would have loved you to qualify what you say as this is a point of view, that what you're saying is not necessarily scientific nor the truth, the universal truth. There is a Greenberg truth based on your experiences, your genes, whatever it is. But I'm afraid that some people here would assume that what you're saying is the truth versus the conspiracy by psychiatry, which isn't. Now, my question is, if you do not like the DSM, what would you replace it with as a professional?
Why would I have to do that?
Why would you have to do that? Okay, so a person comes into your practice. You have to frame a certain strategy, a certain tactic, what you're going to do. And if you're going to base it on the Greenberg scientific method, that method would have to be based on something. Otherwise it's just your point of view, which doesn't give it any credibility. So what I'm saying is, okay, I've heard you about DSM, and I have my own issues with that book. What would you do if you were the psychiatry czar of the United States?
If I was the psychiatry czar of the United States, I'd probably resign. But I think the fair part of that question has to do with how I think what you're asking me is, how else would I frame my understanding of a person in order to treat them?
Okay.
Is that a fair way to put it?
That's good.
The DSM is not a treatment manual. So we should be clear about this. The DSM theoretically isn't helping anybody frame anything about treatment. And there's evidence for this. I'll answer your question about me in a second, but I just want to say, 3/4 of the antidepressants that are prescribed in this country are prescribed without the benefit of a psychiatric diagnosis. So there's a real disconnect between the DSM and and treatment. And I don't even think psychiatrists who use it more seriously than I do, which, if the head of the American Psychiatric Association doesn't use it, then who does? But I don't think that they're framing their treatments that way. Psychiatrists don't treat mental disorders; they treat symptoms. So, but to the fair part, the other fair part of your question, I think that, like every therapist, I frame my understanding of a person through some filter created by my own experience, my learning, my reading, my existence in the world. But I think the most important thing is that a therapist does, and I hope all therapists frame their interventions this way, is to understand exactly what you said is true. I don't know everything. And so therapy is a very powerful intervention. And therapists who aren't aware of their power and aren't careful with it and don't know how to restrain it are trouble. One of the things that I think I'm writing about in this book is the APA's difficulty in coming to terms with its own power. And that's made manifest in no more clear way than in the DSM. Yes?
Yeah, who are the most mentally ill people in the world?
Who are they?
Yeah,
What do you mean?
well, I mean, that's a question.
Well, do you mean like a demographic, or do you mean like a particular disease, or?
You mean what nation or something?
Well, let's put it this way. Who are the most mentally ill people in America? Let's say that. Who are they?
George Bush?
I don't know. I don't know. I don't really know how to answer that question. I think that, but an interesting question. Even if that question could be framed in a way that lent itself to a scientific answer, the answer would have to be nobody really knows, because nobody really knows what mental illness is. Nobody knows how to draw the line between mental illness and mental health. So it's very hard to know how to answer that.
Yeah.
I just attended the Multidisciplinary Association of Psychedelic Sciences, a 5-day conference in Oakland. One of the real interesting things that you may be able to address is a lot of the combat veterans that are coming back are the methods of treatment are not working. And so last week they met with the Defense Secretary and the Secretary for Veterans Affairs to attempt to use psilocybin and MDMA in trying to get to try to disassociate the combat experience from the individual, I guess. I'm a layman in this field, but they were trying to find something that could separate the experience that they had so they could actually talk about it. And I'm wondering, ayahuasca was mentioned, and MDMA and psilocybin and so forth, and I'm wondering if you can address how psychedelic methods can help somebody who has post-traumatic stress disorder or has gone through combat experiences, and why it is that the psychiatric community as a whole seems to be so dead set against it. Is this a question of funding? Is this a question of the inability?
Yeah, well, it's a question of logic. This is something that Steve and I actually know a fair amount about.
There you go.
This
You
is
field tested.
I just saw Rick Doblin last week,
Very good.
who is the head of MAPS. And what they're trying to do is they're trying to get clinical trials. They have clinical trials going for the treatment of post-traumatic stress disorder with MDMA. They're also trying to get one going for psilocybin. So the question you asked, I think, is what's in the way? Well, what's in the way is the drug war, to begin with. And the fact that the drug war originally in 1965 or 7 or whatever year it was that LSD was put onto Schedule 1 has made it virtually impossible to do research with psychedelic drugs. Now, Doblin and MAPS have gotten really good at pitting the FDA against the DEA. Because the FDA, to their credit, says, yeah, this looks really interesting. And the DEA says, we don't care how interesting it is. Those drugs are illegal and you'll send the wrong message. So there's been this conflict all along, and that's a whole different story. But as to the question of why this might work, well, the thought is that PTSD, for example, is a disorder that it's an anxiety disorder. And what MDMA does is it temporarily disables the anxiety circuit. Here I am talking about circuits, but there it is, right? If you've ever had the experience of using MDMA, what you know is the first thing you notice is, my God, I don't think I could be afraid if I had to be. And this can be used as an adjunct in therapy, but more to the point, it can give people the experience of being freed from their fear, which provides them, A, with the hope that they can do that, B, with something to work toward, and finally, in the context of therapy, an opportunity to get past some of the trauma that's been inflicted on them. Does that help? Yeah.
That's pretty good.
It's
sounds a little bit like what you're saying, just in terms of this question, is that this is a useful way to take a made-up diagnosis, which is PTSD, and treat it with a chemical substance and potentially help you.
Yes, that's wonderfully put. And there's an irony to that, right?
Right. That's sort of what the DSM is trying to do.
Yes, and so every once in a while, something good happens. I would argue, in fact, that PTSD is the classic politically created disorder. I mean, shell shock had been noticed before, of course, and combat fatigue or whatever it had been called over the years. But PTSD came into vogue because of the pressure from veterans groups, and good for them. This is what I say about getting the resources. So yeah, every once in a while it works.
It seems to me that the DSM, in some ways, like you said, doesn't have a treatment structure within it, but it, in some ways, sort of is an aid in diagnosing mass amounts of people with certain disorders and allocating resources, like you're talking about. And it seems like your ideas of having someone come in and really deeply understanding someone's true psyche are in some ways idealistic in the current
Some
environment.
ways?
In all ways, yeah, completely
Thanks, Kevin.
idealistic.
Don't hold back.
I mean, thinking about mental illness in prisons, thinking about mental illness in the poor in America. We don't have the resources, we don't have the people to be coming in, and so what? Like I just piggybacking off of this person's question before. What would be? There has to be some kind of replacement. People can't just come in and have these long therapy sessions. What is the alternative? If there's to the DSM,
I don't know.
So what's your idea of an alternative?
I don't have. Look, the DSM's not going anywhere. Whatever usefulness it has, and it will continue to have. It will be put to use. The problem here is, first of all, not every problem has a solution, right? So, and the problems that you're describing, the problem of imprisonment that gets people into jail, the problem of mass alcoholism, the problem of untreated mental illness. There's so many factors that affect those problems. The diagnostic part of it is not all that central, I don't think. So I can't satisfy your question. I'm sorry, but I don't know. And my job here isn't to propose a new way of doing something that nobody's ever figured out how to do. My job here is to say, here's what we're doing, and this is what it looks like, and here are the problems with what we're doing, and here are the myths, I almost said lies, the myths, the fictions that drive this particular attempt to solve the problem, and here are the difficulties that come from that myth. Do I have a better myth? No. Honestly, I don't. But a lot of that has to do with social conditions and cultural conditions that go way beyond psychiatry. They go way beyond anything that we can talk about in the medical model. And they really go beyond the individual. I'm sorry I can't come up with a more satisfying answer. Yes?
If you could reduce it to one main idea, what would it be?
I'd put it in a bottle and sell it.
Sell it. Plus the dime to manufacture and sell it for $1. It's added for me. What would you say is your main motivation for writing this book?
My main motivation for writing this book is that I think that we people deserve to know what the people who have power are up to. And particularly when it's not that, there's no conspiracy to conceal the truth. It's right out there. Nothing that I wrote in this book that I didn't have to go digging. It's what psychiatrists say. We deserve to hear what they say to each other. And all this book really is what psychiatrists say to each other when they think nobody's listening.
I'm interested in the spectrum of patients that you see in your practice because that informs your viewpoint. Do you see many patients, to use the DSM level, do you see many patients with very serious mental illness?
So this is
schizophrenia?
This is a really good question.
Yeah.
So my perspective
Yeah.
is conditioned by the fact that for most of my career, I have not worked with seriously mentally ill people.
Mm-hmm.
If that's the direction of your question. Yeah. So what I would say about two things I would say about that. One of them is that that's also true for the vast majority of mental health resources that are used in this country. So you go back and if you look at the last time this information has been compiled was like 2007. But if you look at the way mental health dollars are allocated, an awful lot of them go to private practice therapists. Now, so that's one thing I would say is that what happens with the DSM has a different relationship to that group. Now, the group of seriously mentally ill people, one of the problems here is that psychiatry hasn't done a good enough job yet of identifying who they are. The DSM was not designed to diagnose seriously mentally ill people. It was designed to diagnose everybody. For people like me. I mean, I don't bite the hand that feeds me too hard. You've heard what I have to say about it, but the DSM was, the people who made the DSM-3 had a constituency, and the constituency were psychiatrists mostly treating middle-class people. And so it was really important to get all those middle-class disorders in there. And so, as a result, the focus of psychiatry has gotten way diluted. I would be really happy if all that money and all that time and all that intelligence was put to the question that I think is behind your question, which is what are we going to do about the fact that there are really seriously mentally ill people out there? I believe that it is possible that there are psychiatric disorders that do work in exactly the same way as kidney disease and as infectious disease. That there's a pathogen. The brain's just an organ, and it can go wrong. I don't know how much of the mental illness out there is the result of that. And the problem here is neither do the psychiatrists. That's what hasn't been figured out. And it's almost remarkable to me that it hasn't been figured out. Obviously, there's a problem with understanding the brain. But even if it's going to be an arbitrary distinction, even if you're going to draw that line more or less arbitrarily based on some combination in exactly the same way that the DSM is made, make that one arbitrary distinction. Draw that line and focus the resources there. People like me have no business collecting healthcare dollars. I believe that. I believe that people should pay me out of their pockets for providing a service to them that helps them with their lives. It doesn't mean that it's not a valuable service. But we don't have infinite resources, and I think a lot of the attention should be focused in exactly that direction.
Maybe one or two more questions?
Okay? Well, we'll go with two. Yes?
So you kind of just started speaking about it, but can you shed more light on the transition from when HMOs and the insurance companies really got into the whole business of psychotherapy? Because my understanding was it was very different for a period of time, and then there was a big shift in the early 90s, I guess.
The golden age, let me tell you. Oh, young lady, let me tell you about the old days. No, look, in the 1920s,
Okay.
Really seriously, I'm not that old. In the 1920s, the New York Psychoanalytic Institute said only psychiatrists can practice psychoanalysis. They took over therapy for medicine. And partly inadvertently as a result, the funding mechanism for therapy became insurance, because doctors were doing it. And that went on for years and years and years, until 1973, more or less, when the thing Steve was talking about happened. And then the insurers began to say, wait a minute, you guys don't know what you're talking about. We're not going to pay for this. And so the struggle was to create a DSM that would keep this wide range of suffering under the medical umbrella. And that worked again for a little while. 1980, the DSM-3 came in, and for maybe 8 or 10 years, it worked pretty well. But then you had two things that happened. One of them is the contraction or the reckoning, the great reckoning in the healthcare field. You know, you can't be spending 20% of GDP on healthcare. Well, you can because we are. It's apparently not a good idea. And so there was a necessity to sort of take that over, and therapists bitched and moaned about it. Oh my God, how can you tell? Well, you know what, really? I mean, we all have to play this game, but they're right in a certain way. And the other thing that happened was Prozac. which came in 1988, and all of a sudden the insurance goes, oh, wait a minute, now. So now, as many of you know, if you fill out those treatment reports, and you have a mood disorder diagnosis, they will ask you, is this patient on antidepressants? And if the answer is no, well, they won't pay for treatment. So, in a nutshell, that's what happened. The last question was yes.
So way back when I was a psych major, I remember taking abnormal psych, and I remember learning that like just about all of the basic disorders were prescribed way more to women than men. And I was wondering if you could speak to that. Is that like society? Is it that doctors are men? Is it just that we don't know where healthy ends and disease begins?
Well, there's a lot of things I could say that could get me in trouble here, but I think that there's the obvious thing, right? Women tend to be the emotional, the symptom bearers for our society.
Yeah.
It's, Freud's practice started with hysteria, which is obviously a disorder of women, although men can have. Men can't have wounds, so they can't have wandering.
But I mean, even like today, even like recent.
Yeah. So what do you think? What kind of answer are you looking for?
I mean, I'm not looking for an answer.
No.
I was just curious if you had any thoughts.
My thought is that the DSM, no matter what you do, embedded in the DSM, no matter what you do, are going to be the prejudices of a society. They're going to be the basic assumptions of a culture. So, for example, hoarding disorder, coming into the DSM-5 this net. As of May 22nd, people who hoard will no longer have obsessive compulsive disorder. They'll have, but the criteria, I don't have the book in front of me, but the criteria for hoarding disorder make reference to the fact that the stuff that you hoard has to not be of any value. So if you hoard money,
You're Donald Trump.
you don't have hoarding. So all you need to know, so why is hoarding disorder a disorder and not a greed isn't? And the answer to that question is because greed is arguably much worse for everybody, including the greedy people, than, collecting, aside from the sanitary problems, newspapers stacked up to the ceiling. So no matter what you do, so why would it be a surprise that the more disenfranchised people are going to be more mentally ill?
That's kind of what I thought, but I just.
Well, I'm glad to confirm what you thought. I have no idea if I'm right.
Thank you so much, Gary.